thought I'd help myself along by saying that Chris Crane is lying to you. Of course, Chris is one of the people I most respect in the world and probably have debated him more than anybody else in my career. Yes, it's definitely alternative facts. So let me give you some alternative facts. I'm supposed to be talking about chemotherapy before surgery. And my first point is going to be that when we make decisions based on weak data, radiation becomes more effective. But not when we do the studies right. And so I'm going to give you locally advanced disease with ECOG 4201, an underpowered study that was stopped early due to low accrual. Study was significantly positive for gemcitabine plus radiation. You lived a little bit longer, about the same amount of time as you would have received the gemcitabine plus radiation, so that you could survive to get that therapy. But then when we did the LAP-07, a large randomized phase 3 trial looking at chemotherapy followed by either chemoradiation or finishing up with chemotherapy and then taking a break. This was the LAP-07 study, a little bit complex because it was a 2-by-2 randomization. Ignore the erlotinib randomization because of course erlotinib did not make a difference in this study. But the CAPE using radiation versus not using radiation, of course the survival curves are tangled up as much as possible, showing no benefit for the chemoradiation in that setting. And that was the setting we thought would be the most effective, as it was a consolidative for the people who remain localized through 4 cycles of fairly ineffective chemotherapy. GI tumor study group study sent a lot of people to the radiation portals. It was a randomized trial of a grand total of 40-something patients, 44 patients. It took only 8 years to conduct that study. Survivals were 21 months. I'm going to go back to this go back a moment. Realized that they were supposed to get 24 weeks of, or actually 2 years of chemotherapy after the chemoradiation, and realized this was an ineffective way of giving radiation. They were giving 2 weeks on, 2 weeks off, and 2 weeks on. And the radiation oncologist will tell you over and over again, boy, was that wrong. But nonetheless, it resulted in 21-month versus 11-month median survival favoring the chemoradiation. 2-year survival looked much better, but realized that only 1 person actually made it through all the treatment. One. An additional 30 patients were treated with adjuvant chemoradiation. They kind of threw those in as further evidence and set the U.S. standard from the 1990s on till recently. But the SPAC-1, that is arguably one of the most complex studies in the way it was presented more than anything else, was really actually a simple study. It was a 289-person randomized 2-by-2, but they randomized a whole bunch of other people that weren't part of the primary analysis, and they presented those in a Lancet article and confused the world. Okay, ignore those other patients. The 289 patients randomized in a 2-by-2 fashion of chemoradiation versus no chemoradiation again got this ineffective way of getting chemoradiation, exactly the same as the GI tumor study group study. And of course, if they got chemotherapy versus no chemotherapy, they got that after the chemoradiation if they got randomized to both treatments. And if you look, the no chemoradiotherapy arm is on top in terms of better survival, and the chemoradiotherapy is on the bottom. The chemotherapy, on the other hand, was effective, less effective if they got chemoradiation first, but the chemotherapy was effective in preventing the recurrence of the disease. And when we look overall on adjuvant therapy trials, when you look at chemoradiation, the first 2 trials, the SPAC-1 had a chemoradiation versus no chemoradiation arm. Survivals don't look so good. Realize that this also, we got better, okay? So I'm not so sure that there's really a difference in these survivals as you look over time. Our scans, our CAT scans got better. We probably found metastatic disease that wasn't there. The RTOG study with chemoradiation on both arms looks about the same as all the other studies with chemotherapy alone. There's not really a clear difference. Again, if you look at a first glance, the median survivals look shorter, but once again, we probably have better scans, better diagnosis, so I'm not so sure there are really significant differences. 5-year survivals weren't reported on the RTOG, just 3-year survivals that I can remember. There might have been a later presentation I forgot about. But bottom line is that we've seen basically the same thing. Chemotherapy makes a difference, but we've never seen the chemoradiation makes a difference, making it questionable why radiation would be used in the post-operative adjuvant setting. So some neoadjuvant basics in life. Surgery is our only curative option as far as we know for pancreatic cancer, and I wish it were a better cure. 10% of patients get cured, or at least they make it 5 years, with surgery alone, suggesting that we're not doing surgery well enough. Probably not. Probably the reality is this is just a really horrible disease, because I think the surgeons have gotten really good at their jobs. Okay? In the most recent randomized trial, adjuvant therapy with chemotherapy will double that survival to about 20–25%, as you saw from the last slide. The three goals of neoadjuvant therapy, therefore, are, number one, response. Okay? We have a lot more patients that are what we consider borderline resectable every year. And the resectable is in the eye of the surgeon, not in the eye of the radiologist. It's in the eye of the surgeon. They have to tell you what they can cut out and what they can't cut out because they know what their limitations are. We do need to sterilize the margins, especially in these borderline resectable patients, so the patients have a chance at having a margin-free resection, because resection margin does play a prognostic role, although adjuvant therapy is helpful whether you're a margin positive or margin negative disease. We are also trying not to interfere with the surgical outcome. Last thing we want to do in a patient who's potentially resectable is make it so they're not. It's happened before and it'll happen again. We're not perfect, but our goal is to try not to cause more problems. So why not take the patient right to surgery? High rate of positive margins, even with modern scan techniques, is pretty common. We'd like to shrink the tumors. We'd like to sterilize the field. More than 20% of our patients don't recover enough to receive postoperative adjuvant therapy after a Whipple procedure or other pancreatic surgeries. So if we're going to get adjuvant therapy in, because this is a systemic illness from the day they're diagnosed, 90% have systemic illness, then why not make sure 100% of the patients get it and give it beforehand? And the other thing is, we're not sure 100% of patients should go to surgery. This is a pretty tough surgery. It's a tough recovery. And to some extent, weeding out the bad players may be a wise maneuver to prevent some people from having to go to surgery that they might not benefit from. Again, this is older data from 2011. This is a very nice publication of neoadjuvant data showing that basically we don't have real high resectability rates. Most of these patients on these studies had actually chemoradiation, but we don't have a high response rate from the treatments as a neoadjuvant setting. And I'm not sure we get a high response rate with anything with this disease, because pancreatic primaries can be very fibrotic. So the combined analysis showed that we can achieve our zero resection rates, though. These studies had differing definitions of resectable, borderline, unresectable. That's been a problem. Even our guidelines, there are several guidelines, ESDO, NCCN, the MD Anderson guidelines, the HPBA guidelines. They all differ slightly. And then there's the intergroup guidelines that are being used for the intergroup clinical trials. And they're all just a little tiny bit different. I've actually had the honor of being on every single one of those guideline panels at some point. And I change my mind every time. So there's no consistency for me. One of the things that we learned was that borderline unresectable patients who had a resection had about the same survival in these articles, but again, there were varying definitions. And they didn't differentiate chemo from chemoradiation in the combined analysis. So does chemoradiation have a higher response rate than chemo alone? There's really actually no evidence of this. Even the combined analysis definitions of response varied over the years. WHO, RECIST, then RECIST 1.1, the primary pancreatic cancers appear less responsive than metastases, which is different than we see in a lot of other diseases. And they're difficult to measure. Even with our high-quality scans right now, there's a lot of debate about response in pancreatic primary. So I would say that we're not clear that the RECIST is the parameter we should use to say a regimen is helping. This is a retrospective analysis from MD Anderson with 129 patients with borderline resectable disease. Again, the response rate was very low. Most of those patients received chemoradiation. Most of them got treated by Chris. 85 patients underwent resection. 95% had R0 resection. And the overall survival was 33 months. And I'm going to mostly convince you should get your surgery done at MD Anderson at the end of the day. But Chris moved up here, just so you know. RECIST response did not predict survival. That's the biggest thing. RECIST did not predict survival. So it's not sure the response is what we should be measuring, but I'm not sure what we should be measuring. Again, MD Anderson has outstanding data on neoadjuvant strategies involving chemotherapy, and I'm confident Dr. Crane will cover these in more detail than I will. So remember, you have to get through the chemotherapy and chemoradiation before getting the surgery. So those patients, that 33-month median survival, maybe because we weeded out so many people in that study. Well, not we, because I wasn't there, but you know what I mean. Why give neoadjuvant therapy? Again, early attempt to gain systemic control, increase the likelihood that all patients get systemic therapy, and the most aggressive tumors will probably progress. So why skip the radiation? Again, during radiation will generally compromise the chemo. There's no evidence that adding the radiation post-operatively saves lives. If radiation doesn't yield significant response or makes patients more resectable, then why make the patients go through it? And this is the biggest question, because we do have more effective chemotherapies. If both surgery and radiation are supposed to achieve local control, let's focus on getting the surgery done right, and that would be the bigger issue. So what do we have? Gemcitabine, nab-paclitaxel in locally advanced disease. We see disease control rates that are very high in small studies. Perioperative FOLFIRINOX in resectable patients led to 90% response rate. And then another study with either FOLFIRINOX or gem nab-paclitaxel in a non-randomized study, 85% R0 resection rate. So again, very positive, but we don't know if they included all the patients that they actually treated as much, because this is retrospective. They just got the ones that they actually brought to the operating room. Perioperative FOLFIRINOX, again, response rate's low, but the R0 resection rates are high. And these are, again, borderline resectable, again, high R0 resection rate, suggesting we can get the patients to R0 resection fairly often with chemotherapy. So, because I'm limited on time, neoadjuvant chemotherapy adequately results in negative resection margins. I think a 90% is pretty adequate. Neoadjuvant chemotherapy produces similar response rates to chemoradiation from what we can see. Neoadjuvant chemotherapy does not negatively affect surgical outcomes, although the data I didn't show. No evidence for neoadjuvant radiation adds to the effectiveness of the chemotherapy now that we have more effective chemotherapy regimens. And don't be fooled by local control as an endpoint. This is actually a failure of chemotherapy. Okay? Local control can be much more important if we were better with the chemotherapy controlling systemic disease. But it becomes less important when you don't control the systemic disease, so that, in fact, actually, although this is not a failure of radiation, a failure of chemotherapy makes it so radiation may not be important by just controlling local disease. So the fact that you get some local control, which I'm sure Dr. Crane will show you, doesn't matter. There are several trials. I'm not going to go through them. They're in your slide set, or they're in the slide set if you want to save them. But there are several trials that are hopefully going to answer more questions about neoadjuvant therapy. We don't have proof that neoadjuvant is better than post-op adjuvant therapy as yet. We never will, probably. I don't think that that trial is going to get done. My last point is that if we want to help, we need to end therapeutic nihilism prevalent in this country. We probably also need to start saying, hey, only certain surgeons should be doing this surgery. That's the reality. If who you did your surgery was a randomized trial, the surgeons who are highly skilled in this would actually win in the randomized trial versus those who barely ever do the surgery. But one of the important things is we still are not getting most of the patients who have potentially resectable disease to the surgeons, so they at least have a chance. So I think I end here.